Okay, well, heart ablation really describes a treatment where we go inside the heart to actually treat different parts of the heart where the short circuits occur to cause abnormal heart rhythms. And it's also known as cardiac ablation. And there are different ways that we can treat the heart muscle or heart tissue that's causing the short circuit. We can do this with heating, we call that radiofrequency ablation. We can do it with freezing, we call that cryoablation. And we also can do it with a new form of energy called pulse field ablation. When you're asking about treating irregular heart rhythms, they can be caused by extra beats in the heart from the top or bottom chamber of the heart, or they can be caused by a rhythm known as atrial fibrillation, which is an irregular, erratic rhythm coming from the top chambers of the heart. And that, again, we can treat with ablation with each of those three forms of treatment: radiofrequency, cryoablation, or pulse field ablation. Okay, well, that's quite a complicated question, but atrial fibrillation can be of two types. One is called paroxysmal atrial fibrillation, where it comes and goes. That usually has better results if the patient has what we call a structurally normal heart and no other real cause for the atrial fibrillation that's related to, for example, high blood pressure or previous heart attacks, and the top chamber of the heart isn't too enlarged. There's another form of AF known as persistent or permanent atrial fibrillation. That is slightly harder to treat. The success rate of paroxysmal AF is usually 70 to 80% success with the first procedure to maintain a normal rhythm. Some patients requiring a second procedure. For persistent atrial fibrillation, it's more like 50 to 60% first time success. And that requires slightly more ablation treatment in order to achieve a normal heart rhythm. Again, the larger the top chamber of the heart is, or the longer the AF has been there, and the other factors that may be causing atrial fibrillation, such as high blood pressure or a previous heart attack, may make the ablation harder to treat. The possible risks really relate to moving catheters inside the heart. The lining of the top chambers of the heart is quite thin, only a couple of millimeters thick. And therefore, there's a small risk of blood leak around the heart, needing a tube or a drain onto the breastbone. Sometimes, rarely, an operation is required to fix that. There's also a small risk of blood clots causing strokes. The risk of that is about 1 in 200. The risk of blood leak around the heart is about 1 in 100 patients. And the other risks are small, but if different forms of energy are used, can damage the structures around the heart, such as a nerve to the diaphragm, and which can affect breathing. That's usually with cryoablation, but this usually recovers. And very rarely patients may not survive the procedure. The risk of not surviving the procedure is about 1 in 1,000. The patients usually recover very quickly, actually. The only wound that a patient has, as it were, is through the tubes that have gone through the top of the leg and the vein at the top of the leg. So it can be sore for about 2 or 3 days there. Usually within a week, people are up and about doing most of the things they need to do with walking around. We just advise not to drive for a week and not to carry anything heavy. And after 2 or 3 weeks, they can go back to regular normal exercise, such as jogging or going to the gym. That really depends on the type of AF that's been treated. If it's paroxysmal AF and there are no risk factors for strokes, they may be able to stop all their medication altogether. For patients who've had more AF for longer or have risk factors for stroke, such as they need blood thinners, then we may leave the patient on some medication to help continue to suppress the AF as well as the ablation treatment.